If you take a blood pressure pill every morning, here is a question worth sitting with. Do you know what that pill is actually doing inside your body right now? Not what the label says, not the single sentence your pharmacist printed on the bag. The actual mechanism, how it works, what it changes in your cardiovascular system every day, what it can do under the wrong conditions, and most importantly, what signals from your body are minor inconveniences versus signals that require urgent attention. Most people taking these medications have never had this explained to them clearly, not because their doctors are careless, because a 10-minute appointment does not leave time for it. Today we are going to cover the 3 most commonly prescribed blood pressure medications for adults over 60, Amlodipine, Losartan, and Lisinopril, in a way that makes you genuinely safer, more confident, and far less likely to be caught off guard by something that was entirely predictable. These are not weak medications. They are powerful drugs that change how your heart, blood vessels, and kidneys function every single day. Understanding them is not optional. It is part of taking them safely. The most important thing to understand about Amlodipine, Losartan, and Lisinopril is that they share one goal: lowering blood pressure, and almost nothing else. They work through completely different mechanisms, produce different side effects, interact with different foods and medications, and require different things to watch for. Taking one of them without knowing which category it belongs to is like knowing you take a heart medication without knowing whether it is a rate controller, a rhythm stabilizer, or a blood thinner. The category determines everything about what to expect and what to watch for. Here is the essential framework. Amlodipine is a calcium channel blocker. Calcium is required for the smooth muscle cells lining your arterial walls to contract. Amlodipine blocks calcium from entering those cells, which relaxes the arterial walls and reduces the resistance that blood must push against. The result is lower blood pressure. The mechanism is direct. It works on the physical structure of the blood vessels themselves. Lisinopril is an ACE inhibitor, angiotensin-converting enzyme inhibitor. Your body produces a hormone called angiotensin II that signals blood vessels to constrict and tells the kidneys to retain sodium and water, both of which raise blood pressure. An enzyme called ACE is required to produce angiotensin II. Lisinopril blocks that enzyme, so less angiotensin II is produced, vessels relax, and blood pressure falls. Losartan is an ARB, angiotensin receptor blocker. It works at the same step in the same system as Lisinopril, but instead of blocking the production of angiotensin II, it blocks the receptor that angiotensin II binds to. The hormone is produced but cannot deliver its signal. The downstream effect on blood pressure is similar. The side effect profile is meaningfully different. 3 mechanisms, 3 different things to monitor, 3 different conversations to have with your doctor. Amlodipine. The swelling that confuses everyone. The most common side effect of amlodipine is ankle and leg swelling, and it is one of the most widely misunderstood symptoms in all of blood pressure medicine. Here is what actually happens. Amlodipine relaxes arteries, the vessels that carry blood away from the heart and into the limbs, more effectively than it relaxes veins, which are responsible for carrying blood back up toward the heart. This creates an imbalance in the lower legs. More blood flows in through the relaxed arteries than flows out through the veins. Pressure builds in the tiny capillaries near the ankles and feet. That pressure eventually pushes fluid out of the capillaries and into the surrounding tissue. The result is visible, sometimes significant swelling in the ankles and lower legs. Socks leave deep marks. Shoes that fit in the morning become tight by evening. The legs feel heavy and full as the day progresses. This is not heart failure. It is not the kidneys failing. It is not dangerous fluid retention from too much salt. It is a direct, predictable, physiological consequence of how amlodipine works. It occurs in an estimated 10 to 30% of people taking amlodipine, and that percentage rises with higher doses. Understanding this matters because of what people do when they see unexplained swelling. Some stop the medication without telling anyone, and their blood pressure rises silently while they believe they made a sensible decision. Some restrict fluids because they think they are retaining water, which is the wrong response and can create its own problems. Some reduce their physical activity because moving makes the swelling feel worse, losing fitness and quality of life unnecessarily. The correct response is to inform your prescribing doctor, not because amlodipine is necessarily wrong for you, but because there are strategies that significantly reduce this side effect. Elevating the legs in the evening allows gravity to assist fluid drainage. Reviewing the dose may help. Switching to a different class of calcium channel blocker may eliminate the problem. These options exist, but none of them happen if the symptom is endured in silence. One additional safety note, specific to amlodipine, that most patients are never told. Grapefruit and grapefruit juice interfere with the enzyme in the intestine responsible for breaking down amlodipine. Consuming grapefruit while on amlodipine can cause the medication's concentration in the blood to rise significantly above the intended dose, potentially causing blood pressure to drop too low or heart rate to change unexpectedly. Grapefruit juice should be avoided consistently while taking amlodipine. Lisinopril. The cough and the emergency to know lisinopril produces two side effects that every person taking it needs to understand clearly, because one is a nuisance and the other is a medical emergency, and they can superficially seem related. The nuisance, a persistent dry cough. The ACE enzyme that lisinopril blocks does not only produce angiotensin II, it also breaks down a peptide called bradykinin. When ACE is inhibited, bradykinin accumulates. In a subset of people, estimates range from 5 to 35%. With higher rates in people of Asian descent, this bradykinin accumulation irritates the airways and produces a persistent, dry, tickling cough at the back of the throat that is worse at night, does not respond to cough suppressants or antihistamines, and does not go away with time. The most important practical point about this cough is its timing. It often does not appear in the first days or weeks of treatment. It can develop 3, 4, even 6 months after starting lisinopril. By that point, the connection to the medication may never cross the patient's mind. The cough gets attributed to allergies, dust, acid reflux, or a persistent post-viral irritation. If you have been on lisinopril for any length of time and have a persistent dry cough with no other explanation, the medication is almost certainly the cause. The solution is a conversation with your doctor about switching to an ARB, such as Losartan, which works through a similar mechanism on the same system, but does not accumulate bradykinin and does not cause this cough. Now the emergency. A rarer but serious reaction to ACE inhibitors is angioedema, rapid swelling of the lips, tongue, face, or throat. This is not a nuisance. It is not something to take an antihistamine for and observe. It is a medical emergency. Angioedema occurs in approximately 0.1 to 0.7% of people taking ACE inhibitors. Less common than the cough, but capable of progressing to airway obstruction rapidly. It can occur at any point during treatment, including after years on the medication with no previous reaction. The mechanism is the same bradykinin accumulation, but producing a severe localized tissue reaction rather than airway irritation. If you or anyone you know taking lisinopril develops swelling of the lips, tongue, throat, or difficulty swallowing or breathing, call emergency services immediately. Do not wait to see if it resolves. Do not take an antihistamine and monitor. The airway can close faster than people expect. A dry tickle in the throat is a conversation with your doctor next week. Swelling of the lips or tongue is a call to emergency services right now. These two things must never be confused. Losartan, the hidden potassium problem. Losartan works by blocking the receptor that angiotensin II binds to, achieving similar blood pressure reduction to lisinopril through a slightly different mechanism. It does not accumulate bradykinin, which is why it does not cause the ACE inhibitor cough and why patients who cannot tolerate lisinopril are often switched to it. But Losartan has its own monitoring requirement that patients are rarely told about clearly. It raises potassium levels. The renin-angiotensin system that Losartan blocks plays a role in regulating how much potassium the kidneys retain. When that system is blocked, the kidneys retain more potassium than usual. For most people whose kidneys are functioning normally and whose diet is typical, This stays within safe range with appropriate monitoring. The problem arises when additional potassium sources are added without awareness. The most common and most counterintuitive source, low-sodium salt substitutes. These products, marketed as heart-healthy alternatives to regular table salt, replace sodium chloride with potassium chloride. A senior who has been appropriately advised to reduce sodium switches to a potassium-based salt substitute and begins using it liberally on every meal. They are now adding substantial dietary potassium on top of a medication that already causes the kidneys to retain potassium. High potassium, hyperkalemia, affects the electrical system of the heart. In mild cases, it may produce muscle weakness, unusual fatigue, leg cramps, or tingling in the hands and feet. In more severe cases, it can cause dangerous cardiac arrhythmias. The symptom progression is not always predictable or proportional. Some people experience significant hyperkalemia with minimal symptoms until they experience significant ones. Beyond salt substitutes, electrolyte powders, potassium supplements, certain meal replacement shakes, and high potassium foods consumed in large regular amounts, including avocados, sweet potatoes, and leafy greens in very large quantities, can contribute to this accumulation in people on Losartan or Lisinopril. This is not a reason to avoid these foods. It is a reason to have regular potassium monitoring through blood tests, which should already be part of the routine care for anyone on these medications, and to inform your doctor about dietary changes and any supplements you use, including products that appear entirely ordinary. What happens when you get sick? This is one of the most practically important things about blood pressure medications, and one of the least discussed. Losartan and Lisinopril are calibrated for a normally hydrated body. When you become dehydrated from a stomach virus causing vomiting or diarrhea, from a fever with heavy sweating, from a hot week with inadequate fluid intake, or simply from reduced eating and drinking during illness, the medication that was perfectly appropriate for your normal physiology can behave very differently. Blood pressure can drop too low. The kidneys, already working harder due to fluid loss, become more vulnerable to the reduced blood flow that can accompany low blood pressure. Dizziness, weakness, fainting, and in significant cases, acute kidney injury can develop faster than most people expect. The medication itself did not change. Your body's internal environment changed, and the drug is now operating under conditions it was not calibrated for. Every person on these medications should have a clear plan from their prescribing doctor for what to do during illness, whether to hold a dose during a stomach virus, what symptoms should prompt a call to the office, and when to seek urgent care. If you do not have that plan, ask at your next appointment. The specific question to ask is, what should I do with my blood pressure medication if I cannot keep fluids down or am significantly dehydrated? This is not an obscure scenario. It is a common, predictable situation that becomes dangerous specifically because most patients have never been told how to navigate it. NSAIDs and your kidneys, one of the most common and most preventable drug interactions in senior cardiovascular care, involves something most people do not think of as a medication at all. Ibuprofen, naproxen, and similar over-the-counter anti-inflammatory drugs. These are purchased without a prescription at any pharmacy. They are used routinely for arthritis pain, joint aches, and back pain, and they directly reduce blood flow to the kidneys through a mechanism involving prostaglandins, signaling molecules the kidneys rely on to maintain their own circulation. When you combine regular NSAID use with Losartan or Lisinopril, both of which also affect kidney circulation through the renin-angiotensin system, the combined effect on renal blood flow can be significant. In the context of even mild dehydration, this combination substantially increases the risk of acute kidney injury. This interaction is not rare. It is one of the most commonly encountered drug-related kidney injuries in people over 60, precisely because the agents involved, a prescription blood pressure medication and an over-the-counter pain reliever, are not intuitively connected in most patients' minds. If you use NSAIDs regularly for pain management and take any of the medications discussed in this video, Raise this specifically with your prescribing physician. Acetaminophen, topical anti-inflammatory treatments, and other analgesic approaches generally do not carry the same kidney risk and represent a safer alternative for many people. Dizziness. When standing, why it matters more than it seems. A brief moment of lightheadedness when you stand up from a chair or get out of bed seems trivial. For a senior on blood pressure medication, it deserves more attention than it typically receives. When you stand, blood pools momentarily in the lower body and blood pressure briefly drops. In younger people with responsive cardiovascular systems, compensatory mechanisms, a faster heart rate, vessel constriction, restore pressure within seconds. In older adults, and particularly in those whose blood pressure is pharmacologically lowered, this compensation is slower. The brain receives slightly less blood flow for a moment. You feel it as the room tilting, a brief unsteadiness, the need to grab something. Most people dismiss it as having stood up too quickly and move on. What makes this matter is the fall risk. A few seconds of dizziness is sufficient to cause a loss of balance. A fall in an older adult can cause a fracture. A hip fracture specifically is associated with significant, long-term consequences for mobility and independence. The chain from momentary dizziness to serious outcome is shorter than most people appreciate. The practical adjustments are simple. Sit on the edge of the bed for a moment before standing. Stand up slowly. Hold on to something stable when changing position. Give your cardiovascular system a few seconds to catch up. But dizziness that is frequent, that has not improved after the first few weeks on a new medication, or that has progressed to a near fainting episode, warrants a real conversation. The dose may need reviewing. The timing of doses may be adjustable. A combination of medications may be creating compounding effects. Reporting dizziness to your doctor is not complaining about a minor symptom. It is providing information that is directly relevant to your fall risk and your safety. Blood pressure monitoring at home. How to do it correctly. Home blood pressure monitoring is genuinely valuable. It is also one of the most common sources of unnecessary anxiety and poor decisions when done without a consistent method. Blood pressure is not a fixed number. It fluctuates throughout every day in response to sleep quality, caffeine, pain, anxiety, physical activity, temperature, conversation, and dozens of other variables. A single reading taken in a rushed moment after walking in from outside tells you very little. A pattern of readings taken consistently under the same conditions tells you a great deal. The correct method: sit quietly for 5 minutes before measuring. Use the same arm every time, the arm your doctor uses, or the arm that consistently reads higher if there is a difference. Measure at the same time of day, typically morning before taking medications, and optionally again in the early evening. Record the readings in a log. Bring that log to appointments. What to do with individual readings? Do not react to them in isolation. A single high reading during a stressful week does not mean the medication is failing. A single low reading on a hot day when you have not drunk enough water does not mean the medication is too strong. What matters is the trend, the average over days and weeks measured consistently. The decisions that follow emotional reactions to individual readings, taking extra doses out of fear, skipping doses because one reading looked good, are almost never appropriate and can create the instability that the medications are designed to prevent. These medications work through a steady, consistent presence in the system. Amlodipine, Losartan, and Lisinopril are not rescue medications. They are not designed to be taken reactively when blood pressure feels high. They achieve their effect through daily, continuous action. Consistency is the mechanism. What to do if you miss a dose? Missing a single dose of any of these medications is common and generally does not require a dramatic response. The general guidance, which should be confirmed with your specific prescribing doctor, is, if you remember within a few hours of your usual time, take the missed dose. If it is close to the time for your next scheduled dose, skip the missed one and resume your normal schedule. Never double dose to compensate for a missed one. Blood pressure medications work through sustained, daily presence. One missed dose will not dramatically change your blood pressure in most cases. 2 or 3 consecutive missed doses may allow blood pressure to rise. Stopping abruptly, particularly with some beta blockers, though less so with the 3 medications discussed here, can occasionally produce a rebound effect. If you miss doses frequently due to schedule or memory, a pill organizer, a phone alarm, or linking the medication to an existing daily habit, morning coffee, brushing teeth, can help establish the consistency these medications require. 5 questions to bring to your next appointment. If you take any of these medications, these are the 5 questions worth raising explicitly with your prescribing doctor. 1. What specific side effects should I watch for with my particular medication, and which of those warrant calling the office versus seeking urgent care? 2. What should I do with my blood pressure medication if I become ill, cannot keep fluids down, or am significantly dehydrated? 3. Are there foods, supplements, or over-the-counter medications I should avoid while taking this drug? 4. How should I monitor my blood pressure at home, and what readings or patterns should prompt me to contact you? 5. At what point would you consider adjusting the dose, changing the medication, or adding a second medication, and what would trigger that review? These are not complicated questions. They are the questions whose answers make taking these medications significantly safer. And they are questions that the standard appointment structure rarely creates space for unless you raise them directly. Amlodipine, Losartan, and Lisinopril are 3 of the most widely prescribed blood pressure medications in the world. They are effective, they are generally well tolerated, and they save lives when used correctly. They also operate through mechanisms that produce predictable effects and interactions that every person taking them deserves to understand. Amlodipine relaxes arterial walls and may cause lower leg swelling, a predictable physiological effect that is manageable once identified, not a sign of heart failure. It interacts significantly with grapefruit. Lisinopril blocks an enzyme in the renin-angiotensin system and commonly causes a persistent dry cough, which often appears months into treatment and is frequently misattributed. Angioedema, though rare, is a genuine emergency requiring immediate response. Losartan blocks the angiotensin receptor and raises potassium levels, creating a specific risk when combined with potassium-based salt substitutes, supplements, or high-potassium dietary patterns, and requiring regular kidney function and potassium monitoring. All 3 are affected by dehydration during illness. All 3 interact with NSAIDs in ways that can stress the kidneys. All 3 require consistent, methodical monitoring rather than reactive decision-making based on individual readings. Understanding this does not make these medications less necessary. It makes you safer while you take them. If this gave you information about your blood pressure medications that your appointments have not had time to provide, please share it with someone who takes the same medications and would benefit from understanding them more clearly. Subscribe for more evidence-based health content designed specifically for adults over 60, content that prioritizes your safety, your understanding, and your ability to have informed conversations with your own healthcare team. We will see you in the next one.